I don't know. Who are those two guys? So, welcome to Spine Conference, and this is Super Bowl weekend, and we're going to start with our Super Bowl predictions. Everybody has to give the Super Bowl predictions. Aaron, who's going to win the Super Bowl?
Carolina.
Carolina?
Carolina.
Carolina?
I'm hoping Broncos just for the fact that I want them to go out.
Broncos?
Yeah.
I was hoping for Broncos.
Broncos?
I say the lights go out and the Broncos end up winning.
Broncos?
And Broncos.
Broncos? What? Mostly Broncos.
I'll
Christina?
go with Carolina.
Carolina.
Mix it up.
All right.
Yeah, I think Carolina's going
All
to
right,
win.
that's even then.
It's pretty even, yeah. Everybody's even. All right. So, just a second. Okay, so I like case-based learning because that's how you can learn things. And we have the distinct pleasure today of having the patient himself here to talk about his symptoms. But I'm just going to get started. 42-year-old man whose chief complaint was back pain. And you can correct me if the history is wrong. There was a slip and fall January 8th, and he was seen at patient first, then referred to the emergency room due to an L2 fracture. In the emergency room, it's very easy to get a CAT scan. So X-rays are obtained, and CAT scans are almost always obtained. So we have a CAT scan and an X-ray on initial presentation. He has his past medical history is very healthy man. Family history, he does have a history of cancer. We had a brother pass away early from cancer. He's a manager, married, 2 children, non-smoker. He takes no medicines, very healthy man. Physical exam, 6 feet tall, 187 pounds. And he has non-focal axial low back pain, so no extremity pain, just pain in the lower back. So anything you want to add to the presentation? Is that pretty much it?
Pretty much.
Okay.
Yeah, it's-
So any questions so far? So 42-year-old man, slip and fall, back pain, and a possible fracture. Okay, so Aaron, what do you see on the X-ray? So the first thing when you go to the emergency room, you usually get an X-ray. It's a very simple, safe study. What do you see?
On the lateral, you can see the L2 vertebrae is not square like the others.
Okay, so it's not square. Keep going from there.
Otherwise, the bones are in good alignment. The disc heights are well maintained.
Okay, so the spine's totally normal except for L2 on the lateral. Now, go over more now. If it's not a square, what is it? Is it a circle? Is it a hexagon? What is it?
It looks like both the superior and inferior end plates.
Okay, so both the superior and inferior end plates are abnormal, okay? Are they? And what about the L2 vertebral body itself? How is it different from the others?
It's minimally compressed.
The end plates are minimally compressed. What else? If you could draw an imaginary line in the front of the vertebral body anteriorly and the back of the vertebral body.
It has some osteophytes.
Yes, it has osteophytes, maybe, but also it looks bigger than the other ones. It looks bigger.
Okay, I see what you're saying.
Doesn't it look bigger in everything? In every plane it looks bigger, doesn't it?
Mm-hmm.
It looks like it's just growing. Okay? So the radiologist read a fraction. How about the oblique views? Anything that you want to add to the oblique views? Do you guys do you know what the Scotty dog is on the oblique views? Do you know that? You don't know that? Okay,
I
you
know
should
the
know that.
Scotty dog. Oh yeah,
Okay.
I see him now.
Good morning. So let me just Alan, let me just bring you to speed. 42-year-old man, slip and fall, back pain, and these are his X-rays which show L2 fracture. Also, the patient's with us today in the audience. He came so he can talk to us about his diseases himself. So L2 abnormality on the oblique views. You can see a Scotty dog. Yeah, can you point it out? Can you point out the nose of the Scotty dog? Yeah, the nose. And how about the eye of the Scotty dog? The eye, right? See the circle? And the neck of the Scotty dog? Yeah, the neck. So the neck is usually where you have a pars fracture. And the foot of the Scotty dog? Down there, that's the foot. So on these views, describe the eye at L2 of the Scotty dog, or the pedicle of L2. Describe it. Can you see it?
You can't see it.
You can't see it. Is that normal?
No.
That's not normal, right? Why? Why can't you see it? Do you know?
I don't know.
Have you ever heard of the owl winking sign? Owl winking sign. So if you cannot see the pedicle in an X-ray, it's a subtle finding for cancer. So it means the anatomy is obscured for whatever reason. So I'll tell you why you can't see the pedicle. Well, I'll tell you why. It's because in Paget's disease you have an obscuring of the junction between the cortical bone and the cancellous bone, and it's manifest here. You can't see the pedicle. So that's one of the things with Paget's. It destroys the architecture of the bone. So that should be a finding immediately on looking at the oblique. So in the emergency room, you always get a CAT scan because the CAT scans are cheap and effective and present in the emergency room. So what do you think of the CAT scan here? This is an axial cut of L2. Aaron, is this normal?
It's not normal.
No, what does it look like?
It looks like it has circles or holes.
Yeah, there's holes everywhere, and there's dark, like blastic areas, the bone formation and bone destruction. And does it involve the front of the body, the right side of the body, the left side of the body, the whole
body.
The entire vertebra? So everything is involved: the vertebral body, the pedicles, the posterior elements, and the very backside, the posterior spinous process. The entire bone is involved. That does not happen in cancer. So in cancer, usually it starts somewhere and it spreads, and it doesn't look uniform like this. Okay. So here's another cut. You can see the entire vertebra is involved. So this is, you're going down to the disc space, and you can see the posterior elements are involved, but then the facet, the other facet's not involved.
Normal.
So yeah, so that's abnormal, but this is normal. So the whole vertebral body is involved. This is a coronal section. On the right, you can see the vertebral body is enlarged. You see how this thing is enlarged, but that may be a fracture. And then on the other view, you can see the entire vertebra is involved. There's a mixed view of lytic and blastic. These are sagittal reconstructions of the lumbar spine. You can see at L2, the bone is actually bigger almost in all planes. The end plates have been compressed a little bit from here to here. And you can see the disease process goes through the whole bone. See how the disease process goes through the whole bone? Everything is involved. Now that doesn't happen in cancer. In cancer, it starts in the vertebral body and then it spreads. It doesn't involve the whole bone like that. So you may ask, do any other disease processes affect the whole bone? Well, yes. I mean, hemangioma sometimes looks like this. This is a hemangioma, but hemangiomas are different. They're very organized. They look like they call it jailhouse vertebrae, like the bars of a cell. You see how the bars? You see how they have these lines that go up and down here? See how they go up and down? And here you're looking at these lines again. They look like bars going up and down. And can anybody guess why in a hemangioma you get these bars? These trabeculi that are organized up and down? They look like pillars, and the reason why they're pillars is the body or the bones the trabeculi are smart. They organize themselves in the strongest way to hold up the bone, because the bone is being removed by this hemangioma or the blood vessel. So the strongest way to hold the structure is a pillar. So what it does is the bones create these pillars in the middle of the vertebral body because it's doing its best to hold up the bone so it doesn't fracture. It's also called corduroy sign. So this is what a hemangioma looks like, but that's not what we have. What we look like, it's not organized at all, is it? It's like it's all sort of all over the place. Okay, so any questions so far about the findings of the X-rays and the CAT scan? So this is the CAT scan is very characteristic of Paget's disease, the CAT scan. The X-ray, you couldn't really tell. The X-ray looked like a fracture. It's hard to say what it was. Couldn't be cancer. But the CAT scan is very characteristic of Paget's disease. Any questions so far? You can interrupt. Okay, so who's Paget's, right? So Sir James, he wasn't Sir James Paget. He became Sir James Paget's at the end of his career, but he was a surgeon. He was 1814, 1899 at St. Bartholomew Hospital in London. He was a surgeon and a pathologist, and he described many things: breast cancer of the nipple, when it gets inflamed. He also described Paget's disease. He called it osteitis deformans. He thought it was an inflammation of bone for whatever reason. He was quite an incredible man. He did everything: surgery, pathology. He did the autopsy on patients himself. He discovered the pathogen for trichinosis, and he was good friends during his life with Charles Darwin. That was. Now, if you want to listen to a great lecture on Paget's, you can just the bottom line is the YouTube URL of a lecture by Stuart Ralston, and it's an incredible lecture. So you can just pause this, and it's on YouTube, and look it up if you want to hear about it. He's a Paget's expert, maybe the world Paget's expert. So what is Paget's disease? Paget's disease is an uncoupling of the normal equilibrium of bone formation and resorption. So that's a lot, but what does that mean? So in the bone, there's two types of cells. There's one type of cell that eats bone, and there's one type of cell that lays bone down. So you may say, well, why do we need this? Does anybody? I mean, why would that be a good thing? Like why doesn't the liver have that, for example? The liver doesn't have these type of processes. Why is bone different from the liver or something like that? Can you think of an idea? Why?
Growth that were changed.
Growth, but this is an adult. I mean, growth would make sense, but how for an adult? Strength, yeah, stresses, yeah. So let's say you're a football player, and you first day of practice, you get beat up, and your bones get can break. So athletes constantly condition themselves and make their bones stronger so they don't break. So this constant stress and force, the bones remodel to this to deal with different forces. So it's a way for us to adapt through our entire lives to different forces on our bones, and it changes. The forces on our bones change all the time. In regards to maybe stress or maybe new physical activities, sort of. So it's a way for our bones to evolve. So if you go from the top and all the way around, at 12 o'clock, that's the bone. So what happens at around 3 o'clock, you see the osteoclasts look like big multinucleated cells, and they eat the bone up, and they create defects. Then the osteoblasts go into the defect at 6 o'clock, and then the osteoblasts lay down bone and strengthen the bone. So somehow the osteoclasts find places that need to be removed, and the osteoblasts then build it back up. And how this is coordinated, nobody knows. I mean, there's some kind of electrical forces that are involved too. So here's the pathology of an osteoclast. You see the arrows in the middle are the multinucleated cells of the osteoclast, which eats up bone. And you see where it says OB, that's the osteoblast. There are small cells that on the periphery of the bone lay down bone, and that's how it grows. And when these two types of cells are together, they work and they create Haversian canals and the osteon. And you can see how the osteon is very organized. It's in layers, it's in concentric layers, and you can see that looks like a very organized structure. Does that make sense? I don't know. Maybe an orthopedic surgeon looks organized to me, but that's what it should look like. And it kind of looks like plywood. You see how plywood, there's like concentric structure. And you can imagine, here's an artist's depiction of the osteon of all these layers of bones that are in circles that make up our bone. And the way it works is through a cutting cone. So the cutting cone on the very top at 12 o'clock are the osteoclasts that go through our bone, constantly eating things away, and then it's rimmed by osteoblasts, and they go through the bone like that, making a circle, and behind it are the osteocytes after the bone's been formed. So these things, these cutting cones roam through our bones constantly, eating bone down and laying it down. And here's the actual cutting cone in a bone. So you can see in the front the osteoclasts, kind of like the vanguard of the bone formation, and then the rimmed osteoblast laying down bone. And it should look nice and organized like that. Now, like we said in Paget's, this is a pagetoid bone. The osteoblasts and the osteoclasts don't talk to each other in Paget's disease, and it's very unorganized. And so the osteoclasts eat too much bone, and then the osteoblasts lay down too much bone, and they're not talking to each other at all. That's the problem with Paget's disease. And you can see here, it's not organized at all. You see how the lamellar, it's not lamellar bone at all. It's very unorganized, as you can see. Does that make sense to you guys? See how it's very unorganized, the bone formation, compared to here. So that's the pathologic, microscopic characteristic of bone formation. Now, cancer can look like that too, and the other thing that can look like that too is woven bone of a fracture. So this, fractures look like that too. So any questions so far of what's Paget's disease, how it looks like? Okay, who hates Cam Newton here in this room? Nobody. Okay. So the initial diagnosis in this case looks like Paget's disease, but one thing ran through my mind immediately is this man's too young for Paget's disease. Paget's disease is a diagnosis in older age, and also this man had a family history of cancer, so I wanted to be sure this was not cancer. So I ordered a CAT scan of the chest, abdomen, pelvis, just to make sure there's no cancer in any of the organs. I ordered a bone scan of the entire body. This is the bone scan. The CAT scan was negative. The bone scan lit up very brightly at L2. You can see that, how it's very dark at L2. Now, Paget's is when the patient has Paget's, the bone scan is a very good test because it shows the entire body, and if there's any other bone involved, it will light up. If there's cancer or a history of metastatic disease, that will light up too. So metastatic disease usually has multiple foci, like in ribs or the pelvis or other areas too that are in different areas. So this is clearly a very hot spot at L2, and bone scans basically show us places of osteoblastic activity where bone's being laid down. And then I also did a SPECT image which shows the whole vertebra lights up. I don't know, that's an axial cut through the vertebra. The whole vertebra lights up in Paget's. I also ordered an MRI scan just to see what the spinal canal looks like, and you can see here the L2 vertebral body. The whole vertebral body lights up in the front and in the back, so anterior and posterior. So this is anterior and that's posterior. The whole vertebral body lights up, and you can see on this CAT scan, see how it's bigger? See how it goes backwards? The whole bone is bigger. Only Paget's disease does that. There's no other disease process that makes bones bigger. So that's something you can keep in your back pocket if you look at x-rays. This is another view. You can see the whole bone is enlarged and the whole bone is deformed. So that's a characteristic change of bones within Paget's disease. Now, what's very important in the spine is if things are deformed, it's a problem because we have these very sensitive structures in our spine, the nerves. And you can see here in the spinal canal is decreased at L2, L3 on the top right. So, yeah, can you point to the spinal canal? Yeah, so it's decreased. So those little dots are the nerves themselves. And right underneath it is what it should look like at L3, L4. So the spinal canal has decreased as a result of this deformation. Is this a problem? Not at this time, but it may be a problem. So it may become a problem in the future where the nerves are compressed. And what you have to do for that is you have to drill it open. Right now, I don't think it's so bad, but it may be something in the future. And that's a very common problem in Paget's disease, is it compresses neurological structures. And who knows, I don't know if this is a myth, like why Beethoven was deaf. Did you guys ever know Beethoven was deaf? But people think that he had Paget's disease, and he had a large, enlarged skull, big head, as he grew older, and the hole where the acoustic nerve came out became compressed from Paget's disease, and he became deaf. So that's a common problem, Paget's disease. So I also did a lot of blood work. The white count was normal. The SED rate was normal. So SED rate's usually elevated in cancer. The calcium was normal, 9.9. Anytime you suspect cancer or some kind of metabolic process, you need a calcium. The alkaline phosphatase was significantly elevated, 189. So not twice as high as it should be. So you can see 189, it should be between 40 and 115. So what processes increase alkaline phosphatase? Can anybody tell me? Paget's disease is one. Liver disease. I'm not sure myeloma. Myeloma, I checked for myeloma. I'll tell you, we'll talk about myeloma in a second. What's the liver disease? And also, just in a metastatic workup, I ordered a PSA, prostate-specific antigen, just to make sure there's no elevated PSA, which could be prostate cancer. Prostate cancer could look like that vertebra too. That was normal. The serum protein electrophoresis on the top was normal, so that rules out multiple myeloma. Make sure there's no cancer of bone. Again, I was being very, very careful. I want to make sure that this person does not have cancer because he's very young for Paget's disease, and also has a family history. The N-telopeptide, which is a marker for bone degradation, was elevated, which is consistent with Paget's disease. Creatinine was normal. So alkaline phosphatase, what can increase it? All sorts of things like infancy, puberty, pregnancy. Obviously, they're not relevant to him. Hepatitis, cholestasis, cirrhosis, liver abnormalities. Paget's disease can increase alkaline phosphatase. Also, osteomyelitis because of bone turnover. Osteomalacia, hyperparathyroidism. So I don't think he has hyperparathyroidism because his calcium is normal. These are all the causes of elevated alkaline phosphatase. In Paget's disease of bone, you can see the fifth line down. It can go up to 10 times normal. So in Paget's disease, alkaline phosphatase is a good marker of bone activity. So how would you Aaron? How would you characterize his alkaline phosphatase at this time?
I guess you would correlate it that the bone activity is not as, it's
It's
less.
abnormal. It's high.
It's high,
but not super high, right? So if it can go up to 10 times, that's like it can
And
go.
it's not even
it's,
two.
it's not even twice. But what you do is you can watch this alkaline phosphatase level, and when you treat him with medicines, because that's kind of a marker of how active the Paget's disease is. So just to go over it again, the alkaline phosphatase is thrown off with bone formation from the osteoblast, and the N-telopeptide comes from the bone from osteoclastic activity. So Paget's disease has both osteoclastic activity and osteoblastic activity, and you can monitor these two chemical markers in the blood. That way we have a way to watch them in his lifetime to see if it's active or not, and if the treatment's effective. Okay, so any questions so far? Okay, so who gets Paget's? Like we said, elderly people get Paget's. It's much more common in older people. It's very rare. It's rare under the age of 50, but there have been cases of very young people, like 26, who've been diagnosed with Paget's disease. It's a lot more common in first-degree relatives. So if you have a first-degree relative, definition being either your parents, your siblings, or your children, you're 7 to 10 times more likely to get it. So what does that tell you? It's genetic. So it's a very high genetic incidence of this. Who gets Paget's? English people get Paget's. So why? No one has any idea. The theory is, so also when they look in burial sites, the earliest found Paget's disease in bones, because in burial sites you can see bones, was in the Roman era, around 0 BC. So the theory is at some point in time, somebody had a mutation for Paget's disease, and it just continued. But also Paget's disease is decreasing in incidence. So the estimate is that Paget's disease, since the highest incidence of Paget's disease was in the 1970s in England, but now it's decreased by 50%. And the countries that have Paget's disease, the most common areas are the United States, North America, Australia, New Zealand, England. So it all comes from England, basically. But it's decreased 50%, so what does that mean? What theory you guys have? Must be some kind of,
Maybe it's recessive.
No, it's got to be some kind of environmental factor, because it's not purely genetic. It's not like we're curing Paget's disease. It's changing. So there must be some kind of an environmental factor, but nobody really knows. The mean age is 59, plus or minus 14, and it's much more polyostotic, or more than one bone being affected by Paget's is more common than monostotic. So again, this is an unusual case of a monostotic. It's usually men more than women. So this is a pagetoid tibia, and on the right's a normal tibia, and on the left is a pagetoid tibia. So this you can tell this because there's mixed lucent and dense areas. You see all the black areas and the white areas. The bone itself is enlarged. The bone itself is deformed. Also, there's a loss of the junction of the cortical bone and the cancellous bone. So in a normal bone, you can see the junction of the cortical bone and the cancellous bone. I'll show you. So you can see that the very white line is the cortical bone, and the inside bone is the cancellous bone. So that's normal in bone, but you can't see that in Paget's. You see how it's obscured? So in subtle cases, that's a way for you to know that it's Paget's disease. And here's a case of Paget's of the pelvis. Same thing. You see how there's loss of the junction of the cortical bone and cancellous bone? The bone is slightly enlarged, and there's also mixed lucent and dense areas of the ilium. Sometimes you can see in the osteoclastic phase. So there's three phases of Paget's. There's Paget's, the osteoclasts dominate, so that's the lytic phase. So the osteoclasts eat up the bone a lot. And then there's a mixed phase where the bone formation and the lucent formations at the same time.
Rapid response room 344.
And then there's the quiet phase, or just blastic phase, where the osteoclasts are not so annoying, isn't it? Where it's quiet. So in the osteoclastic phase, you can see this V-shaped lesion. It's like a blade of grass.
Rapid response room 344A. Rapid response room
Just wait a second.
344A. Rapid response room 344A.
So this is a mixed stage of on the left of both lytic and sclerotic areas. Same in the pelvis. And this is a normal skull in Paget's disease. I mean, this is a normal skull, what it looks like. You see there's cortical bone and a very thin cancellous. In Paget's disease, when it affects the skull, the whole skull enlarges and becomes very thick. And you can imagine that any holes in the skull, which we need, like the acoustic nerve needs a hole, any of the cranial nerves can be compressed in this process. And this is the CAT scan of the pelvis. You can see how unorganized it is on the right there. There's lytic and blastic areas. The bone's enlarged. This is an X-ray of the same pelvis. So, for a long time, there was a theory that, and there actually still is, that Paget's is from a virus. And any thoughts? Anybody knows why they would guess that? Or, but it's like a slow virus because it's in older people, and over time, you get it during your life, and then over time it grows, and that's why it happens in older people, not younger people. And another piece of evidence was in electron microscopy, there were intranuclear inclusions in the osteoclastic cells. The arrow is pointing to an intranuclear inclusion, which you see also in the paramyxovirus, which causes mumps. So there was a theory that Paget's was from an infection, a viral infection that affected the osteoclasts, but it's not clear if that's true or not. So this is way beyond my understanding of medicine, because I'm a surgeon. But there are many factors that have been found that can affect the osteoclasts that are genetically predetermined. So it's probably some kind of mix of genetic predetermination and also environmental. So the bones most commonly affected by Paget's are the skull, the spine, the pelvis, and the long bones of the leg. And very rarely is are the hands affected. So any questions so far? All right, so what do you do? How can you treat Paget's disease? Can you do anything about it? Well, the number one treatment is bisphosphonates. So the most common bisphosphonate is Fosamax, which is made by Pfizer. It's been around for a long time. It's usually it's used for osteoporosis, right? And there are many bisphosphonates. There's Fosamax, Boniva, Auredia, Actonel, Reclast, which is a once-a-year infusion. And they just vary. The difference between all these drugs is just a small side chain is different. So what do these? This is the best. What are these? How do all these bisphosphonates works? What happens is you eat it, and it circulates in your blood, and then it gets laid down in the bone. So if you look at this cartoon, inside people's bones, when they take Fosamax, the Fosamax just sits there inside of the cortical bone. It gets incorporated. And what does it do? When the osteoclast, that big cell, goes into the bone and starts eating it up, it eats into this bisphosphonate and basically kills the osteoclast. So it basically decreases osteoclastic function. And it works in people. So just as an aside, when you take alendronate or bisphosphonates for a long time for osteoporosis, after 5 or 6 years, you have a high incidence of breaking through your bones because it changes the strength of your bone. So this is so that's why bisphosphonates probably should not be taken for more than 5 or 6 years for osteoporosis, because it changes the strength of your bone. Because this bone eating away and laying down is good for you because it gives you an organized structure to your bones. That's an aside. And there's one final thing I want to just go over, is that a very small percentage of Paget's patients can develop cancer. So this is called malignant transformation of Paget's, and in this case is a Pagetoid femur that transformed after many, many years into cancer, into osteosarcoma. So Paget's patients have to be watched. So that's it. That's it. So any questions about Paget's in this case? Yeah.
How do you think it's a localized process in this patient, starting just one bone and
That's a great mystery. And and then the other thing is, like, there have also been cases where you take bone graft. Someone took bone graft from the pelvis that had Paget's disease and put it into another bone for some type of surgery, and it spread. So it's contagious. So I don't know. So that's some people say that it's some kind of, that's evidence that it's from a virus. It's a slow virus. It doesn't rip through the bones quickly, but very, very slowly. But it's not clear. So no one knows why one bone's affected and the others aren't. Why are the long bones affected the spine and the skull and not the hands? I don't know. It's a mystery. It's interesting. What other questions about Paget's?
So if you give the Fosamax to a patient who has more osteoblastic activity, so they've had more abnormal bone growth,
Yeah.
that would not be good for them.
Right, so you don't
correct?
do that.
Yeah,
You don't
so
do
you
that.
just determine that based on the
Phos activity.
Okay.
Yeah, so you can see the patients in a osteoclastic or lytic phase. The osteoclasts are running wild, which is the main, osteoclasts drive this disease.
Right.
So when the osteoclasts are flaring up for whatever reason, you give the patient the bisphosphonate
Okay.
to slow that down. So you manage the disease in that way.
And how often do they generally have to follow up?
Oh, every
Their
6
physician.
months.
Okay.
Every 6 months with a blood test. So the type of doctor that follows this is an endocrinologist or doctors that take care of hormones, not orthopedic surgeons. But we're interested, orthopedic surgeons, we're interested in this because it's a disease of bone. It's very interesting for us. But any other questions? Yeah.
You said that it's more of a genetic type of disease, and then you said it also had environmental factors that could.
Right.
What type of environmental?
No idea.
Okay.
Yeah. I mean, I have no idea. Nobody knows. But there's a lot of research, mostly I think most of the research is genetic into Paget's. And that same lecture that I showed you, he's doing a study on treating patients with Zometa, the infusion once a year in patients, to see if it changes the disease of Paget's. But they found that when you treat patients with Paget's that have no symptoms, it doesn't help them. So you should only treat patients that have symptoms, either bone pain or increased alkaline phosphatase activity. So you can't prophylactically treat Paget's, basically. You have to just treat the people who are symptomatic. So what other questions?
And this patient did not have any family history?
No.
No.
Symptoms prior to the slip and fall?
Well, the only thing I would say was on the very top of my neck, because I used to be a general manager. And at the time I worked for Wawa, high intensive job, and constantly moving things, usually around 50, 75 to 100 pounds, consistently. And I noticed the problem got a little bit worse when I went to Dollar General. And then after that I left, I became a district manager. So now I'm more laid back now, I'm not doing much for the past 2 years. I noticed after I stopped Dollar General, the pain kind of diminished a little bit. So maybe that's the environmental factor. And what we might be looking at maybe depends on the actual person himself. What are they doing throughout their whole life to kind of like cause that? Honestly, I don't know. In regards to what Dr. Antonetta said was, I'm Lebanese, so Greek descent. So it could be, I don't know. So,
Do you know if you have ever had any family ever from England?
I have family live in England.
But from England?
No.
No.
They moved to England.
Yeah.
Yeah.
But Lebanese kind of European, close.
We were right there.
Yeah.
Italy,
Could have been a relative.
Turkey, they all-
Also, Lebanon's always had a lot of trade activity. There's always been a lot of,
Venetians.
yeah.
Venetians.
So
Honestly, I don't know.
probably there's some kind of genetic. We're talking 2,000 years. So somewhere between when Jesus Christ was born and now, you probably had some kind of
I
British.
talk to my grandmother and see what the deal is.
Yeah, there could have been some kind of British pilgrimage or something,
Could be.
Crusade.
Can blame all
yeah,
this to
a
my
crusader.
grandmother.
A crusader one year.
Do you think the apparent decrease in diagnosis rates
Has a
is because people originally thought it was Paget's and now they're more sophisticated and it's actually something else? You're saying in England?
Doubt it.
There's a
Sincerely.
decrease in the diagnosis rate.
I sincerely doubt it, because there's nothing there really. Paget's is very distinct. It's very clear that it's Paget's, so I doubt that that's the reason.
But
Maybe early treatment, that's it, but you would still be diagnosed with it.
yeah, maybe in 1970s, which I think was the date you gave.
Yeah, that was the highest.
Fewer scans done.
That was the highest incidence of Paget's. There was the most Pagetoid people at that time. It was like 5%. 1 in 20 people in England had Paget's. Older people, that is.
But
In
the
the older
diagnosis
age.
was probably not made by scanning. Probably made
X-rays,
by just
X-rays.
regular X-rays.
Yeah, and deformities.
Yeah. What might Paget's look like, or what might other diseases look like?
Cancer can look like that. Hyperparathyroidism can look like that. Infection, but you would know. I mean, you would know if somebody has cancer. You would know if someone has an infection. Hyperparathyroidism, they in the 70s, they should have known that. They should be able to diagnose that. It's an interesting disease. What
From
other?
our
What other?
perspective, it's pretty, clear, the guidelines of what you should do for patients with osteoporosis, like specific exercises, weight-bearing activities, extension, like a lot of things are pretty common. But for Paget's disease, it's not something that is maintaining activity and function is important. But
Well, Dr. Antonettis, I started the allergology. I know it's a little early to say this, but since I've taken the medicine, I've noticed, for one, my posture is a little bit different. And where you was talking about, I used to have the lower back pains a lot. And, I mean, they're there, minimal. And stand up straighter. I have more energy, believe it or not, from the time that I started taking the medicine. In addition to that, I'm also taking the vitamin D and the calcium. The vitamin D3 and the calcium together mixed. And I don't know, I guess maybe also the fact that mentally I'm changing and I'm adapting to what's happening to me. but I'm not, I'm trying to put myself in a mindset of like, I'm gonna fight this and, try to change my life to make it better and watch what I do. And I'm basically waiting to see the endocrinologist. And once I talk to them to see exactly where I'm at, as far as for my alkaline phosphatase, and then I'm going to start more exercising because I actually want to lift weights and I want to do things to increase my bone activity more. So I was reading up on that.
Mhm.
So,
Yeah, you should lift weights.
Yeah, I'm just kind of like hesitant right now because I just want to make sure the spine is healing
Right.
correctly and then take it a step from there. But I've noticed a lot of differences once I started taking the meds.
I started him on Fosamax.
Yeah,
It's
I've
a
been
simple,
week
cheap
now.
medication, yeah.
A week into it now. Yeah.
What other questions? Is that it? Yeah.
Update, thank you.
Oh, you're welcome. Thanks for coming. See you next month.